All good.
All good. Fabulous. All righty then. I think we get cracking. Thank you so much to everyone for joining us for this really exciting webinar. I'm really excited to be joined by these two really interesting members of our team today to give us a much bigger, looking at Birdie from the big picture. You know, we've been doing many different version webinars about the product, what features we're building, why, how they can help you guys. And we really want to take the opportunity to tell you a bit more about the other things that go on at Birdie, how we are looking at the roadmap, where we can go to really build on that better vision, what we really strive for and what we mean by that. So I'm really, really excited to be hosting this event with you guys today. A few bits of housekeeping before we begin. So first of all, I will be recording this session and I will be sharing it with everyone. So in case you have to drop out or you know, a colleague that couldn't come but is registered, we will be sharing this with everyone who is registered to attend, and also we'll be sharing it on the What's New blog so that you can all find this and watch it on demand at any time. Please do use the question and answer box, which if you hover down the bottom of your screen, you'll be able to see a question and answer box. We will be gathering up questions throughout the session, and at the end I'll be asking our panel the questions live, and we'll be able to do a bit of Q&A back and forth. So please do feel free to ask any questions throughout the entire session, and we will be coming to those at the end. Equally, introduce yourself in the chat box. It'd be lovely to say hello to you all, and thank you so much. So I would now like to introduce the panel that we've got with us. So you hear from me quite often. I'm Ellie, I'm the product marketer here at Birdie, and I introduce all the different features and new parts of the product that you guys see. Hopefully you've all seen e-signatures today and that's really excited you. We're really excited to have it out there. We've got Max, who is the founder and CEO of Birdie, and he's really going to be running this whole session, telling us all about the vision for Birdie. And I'm really excited. We've also got a special guest space from Malte, who is our Chief Integrated Care Officer. He came from the CQC and he's coming in to do a bit of a guest appearance throughout the session. So thank you so much to those two. And I'm going to hand over now to Max. Hello, Max. Welcome.
Hello, hello. Can you hear me well?
Yes, we can hear you very well. Thanks.
Brilliant, thanks, and thank you very much, Ellie. Super excited to be here and to speak today about Birdie's vision and mission more than, as you rightly said, the features on a day-to-day basis. And I'm even more excited to be joined by Malte, as you rightly introduced him. I think Malte comes with a wealth of experience on the health and social care side, but also on what the future looks like, and this is really very much what we're going to be talking about as well. So Malte, I'm gonna, maybe you want to give us a brief overview of your background in a nutshell, and then I'll do the same, and then I'll get going with the presentation. Is that all right?
Yeah, of course, Max, and thank you very much for the kind introduction from both you and Ellie, and lovely to join you all today. So as Max said, before I joined Birdie, I was an executive director and board member at the Care Quality Commission, including for their strategy and analytics. So if you want any gossip, you can talk to me about that later. Before that, I also worked in the third sector, including internationally in central government and the private sector. So quite a range of experience that I'm now hoping to bring to Birdie and do really exciting work.
Thanks a lot, Malte. As far as I'm concerned, I've been working in healthcare for the last 10 years now, passionate about technology and social innovation and how technology can help solve many of the issues or the challenges that we see in healthcare and social care. And that's what we're going to be talking about today. So without further ado, let me get going with a little bit of what we're going to be talking about today. Whoa. And my mouse is a little bit moody today. We'll be talking about our vision and where we're heading. Then we'll be talking about the journey to new models of care that we believe are emerging right now. And then we'll be deep diving in a couple of success stories from agencies or groups who are shaping the future of care. Some of them we work with, some of them we don't work with, but from whom we are inspired. And then we'll expand even broader, more broadly to talk about international examples of new models of care. So really today it's about where do we go in the short and medium term, but then where do we see new models of care emerging and how they look like. So it's quite an aspiring and visionary session compared to the other webinars we do, but it gives you a good overview of where we're heading and why we're doing what we do at Birdie. The vision at Birdie, and the reason why we started off Birdie about 3.5 years ago now, is to really build a world in which we can all age vibrantly and with confidence. It started off from a personal story, as far as I'm concerned, with my grandfather, who basically had lost his wife, had Parkinson, and we, as a family, decided to place him in a care home because there were no home care options at all. And particularly considering the family constraints. And he quickly declined, and because he was terribly unhappy in that care home. Because also he was completely lost his landmarks, and we knew that wasn't the right decision, but we stayed with it, and he passed away after 7 months. I have that vivid memory of me talking to my parents and saying, well, maybe we made the wrong decision there, and my parents answering, well, there was no alternative. And for me, it was so sad that there was no alternative and that home care wasn't possible then. It was also, for me, quite striking that aging had to be such a gloomy and sad journey. And for me, quite naively and maybe too optimistically, I thought that maybe we could shape another journey for people who are aging with some conditions, but it shouldn't be always the care home option, and particularly not the care home option with a few chronic diseases and a kind of an unhappy path. So that, plus looking at the overall issue of aging, as we call it, but the fact that we have a very much aging population in Western societies. So where we talk about the funding gap today, where we talk about home care providers struggling with financials today because the care packages are not properly funded, what we realized it was just the tip of the iceberg, and that it would actually get much more dramatic in the coming years and decades if you just look at the demographic effect of a growing cohort of frail older adults. People die later, but they fall sick at the same age, and we have an aging population. So that got us inspired to say, why don't we try to give it another path, right? And think about how could we age vibrantly and with confidence, and alongside plenty of partners. This is what we've been trying to do over the last years, with one mission or an ambition, which is to radically improve the life of millions of old adults. And if there's one thing that at Birdie people listen to when I talk, it's this one. It's really this mission or this ambition is what everybody at Birdie is aligned with, which is to say, let's put at work what we can do, which is technology and innovation and new models that we see across all different experiences, and put it at the service of this ambition of radically improving the life of millions of older adults. Now, it has come clear to us, number one, that home would be the right place to start. And this is really where we're focusing all our attention. How can we support older adults at home? But second, that we would not be the ones delivering the care per se, because this is not really our strength. It is a strength of thousands of care workers and thousands of care managers and thousands of home care agency owners who actually are running the business so much better than we could do. But what we could do, however, is to partner with them to bring them the tools and the innovation to be better at what they do. And this is really what got us inspired. With that ambition, we decided to look at basically all the different issues and struggles that these care providers had today. And we came, I believe, with some humility, not to teach anyone how to run a business, but rather to hear what were their pain points today. And we saw very different answers there. Some of our partners were very much at the early stage of that innovation journey, particularly on the adoption of digital technologies to really leap forward the way they operate. Some others were much further in that journey, and particularly looking at embracing new models of care and even building these. And we'll give a couple of examples of people we've been inspired by who really have pushed forward this idea of how can we deliver much more person-centered, much more preventative care in a much more efficient way thanks to technology. And so we have categorized through a report that we released a few months back called the State of Tech. And it's basically a very good survey and summary of how the industry is going in terms of technology. We have categorized care providers in four basically different archetypes. The first one is basically care providers who are still using paper and pen for everyday operations, from matching the care workers or the caregivers with the care recipients, doing the assessments and the care plans, of course, all the care management pieces. And we have a few of these partners who came to us really with stacks of and piles of paper and archives and so on, and we had to really work through that with them to try to support them in this digital journey. The second archetype is really care providers who start digitizing some of their processes, and usually it starts with rostering, but then a bit of training or HR or supervision or a mix of these. Really, I'd say that the first pain points that they were seeing as really the main challenge, and then they basically embraced some sort of technology. The third archetype is then care providers who are using these software and also a care management system in place, which comes usually second to these first pieces, because these first pieces really typically rostering what was needed day one to be much more efficient. Can I have a rostering software instead of doing that on a whiteboard to match care recipients with care givers or care workers? But then the care management system, and this is really the focus of our work at Birdie, really brings a wealth of new ways of dealing with care in terms of efficiency, but also in terms of quality of care, and really boost the CQC rating thanks to a range of benefits that we could walk through. And so this is the third archetype that we came across and which we help our partner with. The fourth one, which is quite interesting, and really we see an emerging cohort of partners and care providers working through that. It's really an agency or a group of agencies or franchises starting transforming care delivery and utilizing new models of care. And we heard things such as, it's not about hours of care anymore. It's about partnering with the family in the case of self-funded, or with local authorities or CCGs in the case of local authority funded packages, to think more broadly of how can we actually provide more affordable care with better health outcomes by thinking differently about the way we deliver and charge that care, and bringing more elements in that picture than just a certain number of hours of a caregiver. Technology, coordination with other community care providers, and really there's a few things emerging there. But also, how can we really, as I said, be much more person-centered and much more preventative? How can we use very easily some signs from the technology we're using to see problems before they worsen? And we'll talk about that in a second. We at Birdie decided to really work through all of these archetypes. And it's interesting to look at really what has happened over the last year or two with COVID, because while we were working very much supporting archetype 1 and 2 at the beginning, we really saw that technology has gained significant traction because of COVID. Whereas, 30% of care providers were using digital solutions, and that's a survey that we ran. 90% or close to 90% reported and that was in 2019. Sorry, 90% now report that they're using digital solutions for their operations, and that's really the COVID effect and a few other factors. But there's been a 60% boost in adoption of technology. So whereas we were supporting and really bringing benefits or trying to articulate these benefits to the archetype 1 providers, now it's more people saying, okay, well, I got it. I'm adopting technology. Show me what's next on this journey, right? And obviously, there's a few reasons for it. But whereas some of them of these providers told us that they didn't have time to set up the system, and many of you in this call know that 60% said that technology saves them significant time in their operations. We're talking about 30 hours time saved every month. So that was very much the first step, is to say, well, it's going to save me a lot of time that we can dedicate for care recipients and not on admin. Now, that's really interesting also to see that 90% of the technology was implemented due to COVID as well. So this kind of remote working, particularly in the case of care providers, has really accelerated the adoption of technology, and COVID has been the marker of that. But what's interesting is that 40% of these care providers told us also that it allows remote working for the longer term, right? So it was a short-term adaptation to COVID, but also transforming the model of care or the operational principles of these care providers, because they're saying, well, we can actually operate much more remotely now with our care workers, and that actually saves a lot of time beyond just COVID constraints, and that has been really interesting. Now, what's interesting also is that we see, and Malte, I'm so excited you are on this call, is that the CQC also is moving towards new models, right? Whereas, as you are very much aware of, the CQC inspectors would come suddenly on site and inspect your premises, and really, for the vast majority of the cases, would really do a physical visit. Now they're actually saying that they are and will be doing virtual visits, and they will be requesting more and more information in a digital format. So inspectors are asking for access to digital care records when they're not on site. And that is an interesting trend, right? And I think it's a great trend for everyone. Is instead of having this very much fearful factor of waiting for the inspection to happen and not really knowing what the inspector will do, it's just this kind of hygiene of having good care records, digital care records available at hand for any care provider to manage operations in real time in a much more proactive way, but also for the CQC to see that it's under control and that they can have access to these records at any time. I think it will make everybody's life more simple, but it's a very interesting trend that the CQC is also embracing technology as a way not only to make these inspections simpler and probably more tailored and more targeted, but also that we're moving towards that more marginal improvement instead of a big bulk inspection every 2 years or so. What is fascinating, and my computer is bugging. There we go. What is fascinating is when we look at beyond these, I'd say, short medium trends of digital adoption of technology, digital care records, which for me really talks about the 3 first archetypes, which we're really working on at Birdie, and I'll talk about it. It's what also is emerging on the 4th archetype, which is these new models of care and really care providers saying, I want to transform care. It's not all about only operational efficiency or better inspection or improving the lines of inquiries of the CQC. It's really about looking forward. And we'll talk about that. But one example is also the fact that 1 in 5 directors of adult social care services believe that most older adults were not discharged in the right care setting in the initial stage of the pandemic. What does that mean? It has basically, in my view, surfaced a lot of issues as to the broader topic of health and social care. It is just the tip of the iceberg of, rushing older adults out of hospital and very often in the wrong care setting. But this is the kind of handshake that has not happened for many years. And we've been talking a lot about integrated care models between health and social care. This is just one tiny example of the fact that if we are rethinking new models of care, and COVID has accelerated that, there's really a more comprehensive perspective to take. I'm talking about, care and care packages, and hospital discharge is one example, but there's many more examples in terms of how do you want to really support older adults in the best setting for them with the best care at the right time by the right people. And this is just an example. Another example is all the press review that has happened, and we're a big fan of Jane Thompson, whom you probably know, who's the CEO of UKHCA, but she's very present on social media because she's also arguing for new models of care. And that relates to funding, but also to having more appropriate funding targeted towards the right care packages, thinking differently about outcome-based care instead of just hours of care, and trying to really lobby for local authorities to embrace a wider range of options, not just billing by hours of care or by the minutes, obviously. And that is also, for me, a strong indication that we are evolving towards new models of care that are emerging. And of course, it takes time, and we've been talking a lot about it, but COVID has been a significant accelerating factor, to my view. Now, at Birdie, we want to help partners care extraordinarily. This is really our motto internally, is to say, what can we do along this journey of these 4 archetypes, and focusing on the 4th one today. How can we support our care partners or these care providers to care extraordinarily? And there's a big, there's a chart that we love, which is this wheel, which is basically taking a comprehensive or holistic perspective at the care journey. And for us, it starts with assessing the care needs of an older adult, and really making sure that we go deeper and we make the life of care providers much easier in terms of the assessment step. And so we're using, as you are all aware, quite a lot of the different assessment frameworks, and we've tried to really listen as much as possible to our partners to build the right assessment in the right place with the right modularity. But then, e-signature is another one where we try to facilitate also all the pain points along the assessment process. But for us, that's just the first step. The second step is the planning, right? If you do the right assessment and you have it in real time and you have that dynamic assessment model, then you can plan and continuously replan if necessary as well, but you can plan better. And one complaint that we had from a few care providers is to say that the care packages often are too generic, and that a better assessment leads to a better planning that is a bit more personalized. But also that if you do that digitally, then you can actually replan much more often than the 6-month to 12-month review of the care package. Then the delivery, you're very, of course, much acquainted with our care management system. Technology can do so much in the care delivery. Of course, to support in the care management side of things, but for us, there's a wider range of opportunities from home technologies such as sensors and motion sensors and so on, to bringing, as I said, other stakeholders in the picture, typically family members and next of kin. And then the last bit is the improved care, which is something that we're working on. And obviously, we want to work on that with our partners to see where we can help and add value. But if you think about that wheel, if you do the assessment right and the planning right, and you help deliver the best care, then you can continuously improve the care based on the information you're collecting, on the real-time understanding of the health and well-being of an older adult, and replan accordingly. And that is really this virtuous circle that we're trying to build to really help all partners go from let's go digital, let's adopt the right tools to digitize operations and gain efficiency, but then let's also embrace new models of care over time through that wheel of improvement. And we've done that through, and you're familiar with that, a range of different solutions that we've pushed over the last 3 years, working days and nights. And I can tell you, the team is working really, really hard to push this out ASAP, because we know that partners are really in need of some support and the right solution. So an agency hub, you're very familiar with that, a caregiver app as well, but also a family app, which we hear is really useful for many family members, particularly the ones who are further away from their loved ones. Birdie Analytics, which really helps agencies and groups to improve in their operations on a day-to-day basis. And then, as I said, a range of integrated assistive technologies such as motion sensors and fall bracelet and tele-alarm and so on. And we're looking at other elements such as new sorts of home connected devices, and we're piloting a couple, and we're getting grants to actually trial new things so that it can really broaden this number of technologies available. That's what we've pushed out today, and there's a lot more coming. Now, what's interesting is to look at, okay, that's great to go through these 4 archetypes. Let's look at the 4th archetype. Max, we understand you want to improve care, but what's coming up? What give us examples of what's being developed or trialed? And for us, really, as I said, it's about technology supporting partners to be better at what they do. But if we even are more forward-looking, it's about understanding that the entire health and care will happen at home. The future of care is at home, and for many reasons, including the fact that we want to keep all the adults outside of hospital as much as possible, or prevent them from going to the hospital as much as possible. We know that because of COVID and a few other factors, as long as possible, we'd like to keep all the adults outside of care homes if they wish so as well. And so there's really this ongoing trend of saying it's not all about hours of care for dumb care or living care. It's about how can you create an ecosystem at home that really supports these old adults as long as they wish so to remain healthy. And that's where we see a wealth of opportunities. And that's where we also see that care providers will be at the heart of that journey of new models of care. And I'll hand over to Malte now, because we'll give you a couple of examples of things we've tried to really, give you an oversight of what it could look like in the future. And then I'll give examples of other care providers we've seen out there, which are not working with Birdie, but from whom we've been inspired as well. Malte, you want to go ahead?
Great, Max. Thank you very much. So there's 2 aspects of what Birdie is exploring at the moment when we talk about bringing care to the home, and that the future of care is at home. And I want to briefly talk to both. The first one is about how we can use new technologies to help to improve prevention, to identify issues and risks for care recipients earlier, and as a result, help them to increase their well-being or maintain their well-being, but also to live at home longer as a result. So that's still very much about how technology can complement what you are doing today. And a key piece of work that we've been doing in this space so far is to pilot with a care agency called Maddox Healthcare in a number of local council areas the use of home monitoring sensors, and the extent to which it's possible by looking at data of how people are active at home and how what they're doing at home, how you can use that data about their activity complemented with the observations from the care workers, who after all are visiting the care recipients daily, if not several times a day. And when you bring those 2 aspects together to see whether you can actually identify a risk earlier, and importantly, tailor the care package as a result. And the findings that we've had from that have been impressive. I mean, it was a small study with a small number of care recipients, so we can't extrapolate that yet in an academic way, but it's very promising from our perspective. First of all, the number of alerts that have been raised from the census and in the conversations with the care managers, care workers, over half of the alerts that have been raised have actually led to a change in the care plan, if not a medical intervention as a result. For example, the identification of an infection, a urinary tract infection that requires an intervention from the GP, but also aspects like changing patterns of behavior, for example, sleep patterns that led to someone being supported with onset dementia much earlier than otherwise probably would have been the case. But not just that, we also found that the tailoring of the care package as a result of this information also led to a reduction of the number of people that were admitted to residential care over the same period of time compared to the average. And that's obviously also a big part of what we want to achieve, this ability to keep people at home longer. We're going to continue to do that work, and we've got a very exciting grant through the Eureka program with Innovate UK, the big UK funding body, to explore further what type of home sensors, wearable devices, and other information can complement home care in a way that really generates actionable data and insight for you, so that you can continue to tailor care for care recipients and keep them at home as long as possible. Max, if you go to the next slide. So that was about how can we use technology to further help and complement and improve the care that you provide at home to help people to stay at home as much as possible. The second aspect that we're then looking at is, if what is happening in people's homes and the care that you provide makes such a difference to their day-to-day lives and their well-being, how do we connect that much better to other healthcare pathways that they're already involved in? How do we connect that to things like primary care and other services? And in this space, we've just launched a fascinating piece of work in March with an agency called FOSS, together with the council and the commissioners, the NHS commissioners in Nottinghamshire, where the care workers are monitoring and identifying early warning signs of potential health risks, so-called soft signs, where they have been identified for a care recipient. A carer can go in and also take some vital signs like blood pressure and temperature or heart rate, share that information in a structured way alongside those observations with the GP. And the GP can then decide there and then what the right intervention is. And again, we've only launched this in March, but we already have a number of case studies that's shown that issues have been picked up early. On the one hand, things like infections being dealt with remotely by the GP by prescribing antibiotica over the phone, but also that actually the care workers have been able to deal with a number of sort of low-level issues and provide assurance through a conversation with the GP that otherwise might have resulted in the care recipient having to go to the GP or the GP doing a home visit, but actually there was no concern in the end after all. And we believe that this example of sharing information and the insight and the understanding that your care workers have of care recipients in their own home, sharing that with other parts of health and social care, like primary care, is a huge potential, because no one understands care recipients as well as your care workers do, and the rest of the NHS and care doesn't really make use of that potential at the moment at all. Another example that we're exploring is to take this idea to pathway like discharge, when people come out of hospitals for 3 to 6 weeks, to what extent actually when they also receive home care, personal care, that support the information and the observations from that support can be shared with the discharge teams and community teams to make sure that they provide the right support, not just on the personal care side, but also on the physiotherapy side, and ideally prevent people being readmitted to hospital if they don't improve enough. So those are a couple of examples where we want to see care going in the future, and where we also believe home care has a huge potential and opportunity to be a really big part of better pathways and care around people in their own homes. Max, back to you.
Thanks a lot, Malte. There's another example I'd like to table, which is really the Good Care Group, with whom we're not working today. But we've been very inspired by the results they've achieved by really looking precisely at this more comprehensive approach, particularly looking at the data. They have looked at the data into details from the software that they're using, and they have a bespoke software that they've built over time to really analyze each of the visits outcome and draw correlations from different visits of care recipients. What they've come to in terms of achievement is the following. They basically have reduced the risk of fall by 76%, the pressure sore rates by 89%, and the emergency response for UTIs by 68%. And you can maybe, there's a lot of available information online on this matter, because they've, talked a lot about it to really explain that it's not that difficult. Provided that you embrace this journey of technology, you could actually work much more towards a prevention model and lower hospital admission rates, emergency responses, or risks of fall. The other examples we're very inspired by is Homestead. Obviously, everybody is familiar with Homestead. Again, this is not someone we work with today, but we are inspired by the way they operate because, as you very much know, 20% of their branches are rated outstanding. Where they're going is really saying, well, understanding meaningful changes and patterns in the home enables better care planning and enhanced care delivery. And that's Martin Jones saying this, the CEO of Homestead. They've gone through a journey, and they're still going through that journey of saying, well, actually, the future of the elderly care will be at home, to the extent that home will become the hospital ward of the future. And with that in mind, they're actually piloting a series of different initiatives to try to see how can we leverage technology and data and new care models to really make home the place to actually care better for the older adults, as long as it's possible. But that means shifting all the costs from the healthcare system towards the social care system, because we know it's going to be more affordable, it's going to be cheaper. But more importantly, we know also that with this much more personalized, much more regular, much more preventative approach, you will achieve better health outcomes. And so we are inspired by Homestead also through that kind of innovative approach to the future of care. Now, Malte, I know that you had a look at a few US models in terms of what it could look like. Do you want to touch base on that quickly?
Yeah, so obviously we don't say that what's happening in the US can be easily replicated in the UK, nor would we want that to be the case. But in the US, there are some really interesting examples from companies that have started to realize this idea of providing healthcare at home. So the three examples I wanted to mention are building on each other. The first one, a company called Current Health, who are actually also doing a little bit of work in the UK, are providing a sensor device that people can wear on their arm that sends regular 24/7 data about vital signs, sort of heart rate, temperature, etc., about the client, which is particularly important for people who've got a chronic long-term condition that needs to be monitored. But the important, interesting element about this particular example is that they also provide a first response. So if any of this data shows that there might be a concern, there is actually someone who gets on the phone, calls the care recipient in their home, says, what have you been doing? What's going on? Is this something I should be worried about? And if they are, then they support with the follow-on, for example, with a clinician, it needs to be provided. The second example, from a company called Clover Health, who actually also provide insurance in the US. But the interesting aspect of what they're doing is that the information that they receive from care recipients and care that's being provided is turned into a platform that helps the clinicians to identify the right issues and take the right choices and improve the prevention. So it's a decision support tool on the basis of the information that says, in this sort of circumstances, have you asked about this? Have you looked at this particular risk? Have you thought about this particular issue? And as a result, help improvement and help prevention and taking the right actions. And then a third example, again on top of that, is a company that's called Dispatch Health, located in Denver in the US, who've actually gone one step further and who said, we can send people into care recipients' home within 2 hours and provide them with nurse-led care. So anything that's sort of an urgent care, wound treatment and otherwise, a nurse can deal with really, really quickly. And it's another interesting example of how the dynamic between going to the doctor or the nurse coming to you can shift in the future. And a lot's happening in the NHS at the moment as well about community response and response teams into people's homes that I think over time will replicate that similar example. And wouldn't it be fantastic if we've gotten to a world where these aspects of care could be shown also to work here? We understand how someone is doing at home. We call them up if there's an issue to see whether everything is all right. The doctor is actually supported in the best way with that information. And if there is an issue, someone comes to your home and helps you out within a couple of hours as a result. So I think that's a really exciting future, and we're going to work really hard to bring some of those ideas also to the work we're doing here. Max, back to you.
Thanks, Malte. I just want to finish up with this famous life curve, and if some of you are know me a bit better, you'll know that I have an obsession, which is the life curve, to the extent that some people can't stand this life curve anymore. But for me, it's an excellent representation of where we want to go. The life curve is basically a conceptualization of frailty and decline put forward by the University of Newcastle, actually the Institute for Aging. And these guys have basically represented that in a chart where you have the x-axis, which are the number of years, past 65 years old with 2 or more long-term conditions, looking at the years until someone would actually pass away. Then you have the y-axis, which are the activities of daily living, which you're very familiar with. And that is basically a representation of an older adult's level of independence. The more activities of daily living, or ADL, they can perform, walking, bathing, cooking, and so on, the more independent they are. The fewer activities they can do and for which they need help, the more dependent or frail they are. What's interesting is that that curve is not linear, right? If you look at it, there's a quite rapid decline happening, and then the curve stabilizes at a high level of dependency or frailty for quite a long period of time. And there's many reasons to that. Chronic diseases, long-term conditions, which are more, I'd say, on the medical side of things. But also, there are issues relating to the care and health system as it is organized today. And one example is falls, right? Very often a fall has happened. There's no broken bone per se, but the old adult, a lady, will lie on the floor for 2 days in a bathroom because she lives alone before being rescued by someone if the care giver comes only once or twice a week. And that is highly traumatizing. The person will be rushed to the hospital, stay 3 weeks in the hospital probably, and we can see that after that, that person will have declined quite significantly. Infections, I mean, urinary tract infections, and that's the reason why the Good Care Group has worked on that specifically. UTIs, as you all know, happen very often, and very often they're seen too late. And if we had seen it early on, we could treat it much more easily. And then it would avoid a lot of issues, such as being rushed to the hospital, or obviously avoiding falls. And mismedication, one out of 3 cases, there's some issue with medication administration at home, whether it's the wrong medication or it's partially administered. Of course, not the fault of the caregiver whatsoever, but there are sometimes issues with medication, which lead to an acceleration of the decline. Again, it is possible for all these different elements, which are not in the register of medical treatment, but more in the regimen of care efficiency, care coordination, prevention, person-centered care, to use technology to really address some of these issues early on, or prevent these issues from happening, so that we could actually give a total different shape to this curve. And we've talked to plenty of geriatricians. We have advisors telling us we could easily lower hospital admission rate by 30 to 40% if we were to see these signs early on and address them on time. And so we could easily flip this curve and give it this shape, where you basically keep all the adults. That delta is a much healthier, happier life with some needs in terms of support. You've lost me and I'm back. Yeah. So that curve is much better for everyone, obviously, the older adults, the family, and the healthcare systems overall. With obviously a much healthier life, it doesn't mean that you don't need care providers. As a matter of fact, you will need them for much longer. And that is the interesting part of it as well. So I'll stop there. But this is really the long-term vision of Birdie, is to flip this curve and bring a much more preventative, person-centered model to care by enabling and empowering and supporting our care providers to go towards these new models of care. I'm sure there are questions, so I'll stop talking because I could be talking for hours about this topic, which is a passion of ours. And Ellie, I'll hand it over back to you.
Thank you so very much, Max and Malte. That was absolutely fascinating. From reminding us what our vision and mission is, to going through what our product is today, and the way that we centralize around the client and how they will have the care delivered, to looking at the trial with Medax, Malte. It's really reminds me just how much of the different things are going on to try and really radically improve care, and the work that we are trying to pursue in order to really reach that goal. So thank you so much for sharing all of these really interesting cases with us. Now, we had a few questions throughout. Predominantly they were sort of product and like roadmap, what's coming next question. So I answered them during the session. We had a question around that went to Malte, and I believe you've answered it. Now there's the question, I'm not sure this is a question exactly. Apologies if I mispronounce your name, Nucukio, sorry, I might be mispronouncing it there. I don't think there's a question in that particularly, but I was thinking what would be nice if anyone does have a question they would like to ask. Would you want to raise your hand using the raise hand bar, and we can actually unmute you and you can ask a question live. I think that would be really nice to get some interactions with people should they wish to. So please do holler if you would like to ask a question live to either of our panelists, Max or Malte, or both. Do we have any questions for anyone? Maybe not. Maybe Malte, if we haven't got anything coming through, it'd be quite interesting for you to discuss a little bit more about what Ruth asked you around looking. It was related to the prevention and hardware monitoring, which I thought was quite interesting. Maybe we could go there for a second.
Yeah, happy to. So Ruth's question was, or point was about the fact that there is, particularly in discharge at the moment, and particularly over the last few months during the pandemic, that there's been quite a lot of issues with discharges and discharge information when people get discharged from hospitals into care. I presume it's the same for home care or care homes, where there's been issues with the information that has been shared. I mean, there's been wider issues of course around COVID and COVID infections, but leaving that to one side now. And certainly when we've been talking to some of our agency partners, they've also highlighted that quite regularly there's information missing as part of when they're taking someone on who's been discharged, things like the detail of the medication record, etc., which then means they have to spend a lot of time finding out that information, confirming it, etc., to provide the provide the right care as a result. So the work in the background that we're doing around this is actually what the opportunities are to better connect different data systems with each other. So in the same way that we talked about that we think there is significant opportunity from sharing observations of what your care workers see and know about care recipients with other parts of the NHS, whether it's GPs or otherwise, it also goes the other way. And we know that there's a host of information that's currently available to the NHS that would be really helpful to you and your care managers to provide better care, that is very difficult to access, or you have to do it around the phone. The best example here is medication data. You will already be using Birdie to do the medication schedules, et cetera, but you're still in a situation where you have to take the medication information if a new client arrives from the GP or otherwise, the discharge information, enter that into Birdie, and then make it part of your care plan. So with the best intentions and the most attention, there is a risk here from transcribing that data from one system into another. We would love to get into a place where medication data can be shared directly from GP systems into Birdie. And that's going to be possible. Technically, we already know it's possible. The biggest challenge here is that some of the data permissions that still are in place, or the data permission rules that are in place, mean that a lot of this data can only be seen by registered clinicians or nurses or pharmacists. This obviously means that if you don't have someone with those qualifications and registrations on your team, you're actually not allowed to access that data. So there's a lot of conversations going on nationally about how those permissions can be changed that make it actually a lot easier for care providers, social care providers also to access that information. When it then comes to discharge.
Oh, yeah. Sorry. I was just going to ask you a question on that, but continue. I stopped your flow.
Okay, so when it comes to other information like discharge information, I think that's a sort of next step, right? So how relatively straightforward can we make it for that information to be accessed by someone using Birdie's platform because it's already available? A lot is happening in this space nationally in terms of shared care records, etc. But all of that is sort of 2-3 years away, we believe, because it's complicated from the technical perspective. What we really want to achieve is to demonstrate that it can already be done, and demonstrate that in a particular area with a particular partner to make happen. So that's on our list of priorities over the next year as well. Sorry, Ellie, go on.
Not at all. I was going to ask you if you think that the data sharing is one of the biggest barriers to some of this sort of improvements in care, and when you talk about integrated systems and the barriers we find within them quite a lot, and data really is a big one, and we're all very conscious, you know, GDPR, client data, data privacy, it's so important and personal, and yet we can see such benefits of sharing some of this information to really improve someone's life. Do you think that is really one of the biggest areas that we need to find solutions for, over actually the solution? Like, do we know the solution better than actually the gateways?
Yeah, so it's definitely one barrier to relatively quick wins that we know are possible, like the medication data straight away. I definitely wouldn't say it's the only barrier. So the next one is that it's really easy to say, hey, let's share lots of data, without actually really trying to think through what data is most valuable. And some of our conversations, we've been quite surprised what information people say they want most. So when we've been talking to GPs about what they data find most interesting, most of them have said, first of all, just knowing that someone is receiving home care would actually save me most time, because quite often I have to be on the phone finding out, you know, where they get care provided and how do I get hold of them if there's an issue, etc. And that wasn't the first thing on our list when we started those conversations. So contextual information can also be really helpful, but that understanding of what data makes a difference. And then another challenge, I think, is going to be that particularly the NHS is used to the fact that if someone says, hey, why don't we collect some data and share it? Everyone finds that relatively straightforward and agrees, but that's because they don't have to pay for it as much. Whereas if we go into a situation where we say, why wouldn't every home care provider collect some additional information, observations from our care recipients, so that we can share it locally with our primary care partners? That's a great idea, but unless someone works with the care agencies to say, and this is how you can afford another 5 minutes on every visit once a day to actually collect that information, it's not going to become viable for you, right? So I think there's also something about understanding the commercial realities, but also incentives for how the NHS and social care work together, simply because they're very different systems. And I don't think that's quite been understood and correct enough yet from our perspective.
Yeah, no, that makes total sense. Thank you so much, Malte. That was super interesting. I have a question from Melanie, and she's asked me to raise it with you guys here to get a better answer on it. So I'm just going to read it out to you guys, if that's okay. So Melanie says, we had a CQC inspection last week. They were impressed with Birdie. Yay. The only thing they picked up on was a lack of proper falls risk assessment. Birdie tells me how many times a client has fallen and where, but not the possibilities and risks of why, brackets, medication, frailty, etc. We used to use the Tellamore form in our old paper risk assessments. Tellamore used a number system on why falls could happen and the total score. Can this be improved? Just to give you guys a bit of clarity, I went back to, I signposted to Beth, who is obviously in charge of our assessments, to say that would be a great thing to raise with her, but I'd love to know any more you guys have to say on it.
I think, I don't know, Malte, if you worked on that assessment specifically, but my recollection, and Melanie, I'll be super honest with you, I haven't caught up with Beth, who is a product manager on this for 3 or 4 weeks, so I'm not entirely sure where she stands there. So I know we looked extensively at different falls assessment frameworks, and there were questions on the clinical side on whether one was more recognized than the other, and whether we could actually propose one as a standard or a few different ones. So I'd like to catch up with Beth on this and get back to you with an answer on whether it's just part of the roadmap and in the coming, or whether there's more of a clinical side question here for us that we are sorting out. And surely we'll bring the Telemore proposition on the table during that conversation. So if you bear with us, I'll get back to you in a few days.
Melanie, I'll make sure we've got your contact details to do so. Sorry, Malte, were you about to say something? I think I interrupted you.
Well, I was going to add a more general point on this, which is that also over the next year, we want to start looking at what additional assessments we can potentially make available to you, but also to other agencies, obviously also agencies that are focusing on more specialist aspects, like complex care support, for example, to people with severe physical injuries, etc. So we are aware that there's a number of assessments that are valuable to some of our agents and still to provide, and we want to develop those in a way that makes it really easy to use. And that are the right ones. So what we don't want to do is suddenly for you to have 50 assessments on the list that you sort of have to click through and find what the right one is, but also to find a way for you to use the ones, to make it easy for you to use the ones that you actually need and that are useful for that. But that's a greater sense of detailed assessment around specific issues is part of our roadmap for the next year as well.
Definitely. Fabulous. Thank you so very much. And we've got a couple of minutes left. So if anyone would like to ask a final question to see us off on this session, we'd love to hear from you. Otherwise, it's been a total pleasure to talk to you both. Thank you so very much. It's really nice to be able to hear from the leadership of Birdie telling us. I find it really beneficial as well as a Birdie to hear exactly what we're up to, where we're going to. It's really a partnership is really the key word, and I know that that Max referenced it a lot throughout the session, and we really do genuinely care extraordinary amounts about making sure that you guys have the best experience, that we are working together to get towards a brighter future for care. And I can assure you that we are all spending a lot of time trying to think about it. So please do keep sharing your insights. You'll have seen in the chat, if you look at the responded questions, you can see the roadmap is linked in there. So please do check it out. It's a really great place to see what we're working on, what we want to bring to the forefront within the product. And it has an opportunity for you to add comments. So please do share your thoughts, and it really helps us to gather those insights about what our partners need and what they want us to work on and prioritize first. So always really, really want to hear from you all. If there's nothing else, I would like to say a massive thank you to both my panelists and to everyone who has attended. Thank you very much for coming. Cheers for having us.
Thank you so much. Bye-bye, everyone.
Bye-bye, everyone. Thank you, everyone.